Transport is not just about putting a patient in the back of the ambulance and heading to the hospital. As an advanced EMT, you are making a clinical decision every time you choose how and where to transport someone. This is a critical part of patient care, not just a logistics problem. When done right, it can save a life. When done wrong, it can delay treatment or even cause harm. Let's start with the foundation of all transport decisions: evaluating patient condition. Ask yourself the key question: is the patient stable or unstable? This isn't a guess. It's a judgment based on clinical signs, things like vital signs, mental status, and overall presentation. Let's look at stable patients first. Stable patients have normal or near normal vitals. They're alert-oriented and don't show signs of immediate decline. These patients can tolerate a longer on-scene time if needed. You can take a little more time for a thorough secondary assessment, careful splinting, or getting a more detailed history. That doesn't mean you're slow, it means you're deliberate. You're working with time on your side. Now, let's look at the opposite: unstable patients. These are patients with low blood pressure, altered mental status, serious respiratory distress, signs of shock, trauma, stroke, or cardiac compromise. In these cases, the clock is not your friend. You need to act quickly. That means rapid assessment, basic stabilization, and immediate transport. This is where we say, if the patient is unstable, you need to be unstable staying still. In other words, get moving. Don't try to fix everything on scene. Focus on what's life-threatening, package the patient, and go. Why is this so important? Because transport is not just a ride. It's part of your treatment plan. Every decision you make, from whether to stay or go to what hospital you choose, can have a huge impact on the outcome. A stable patient might be fine going to the closest facility, but an unstable patient might need a trauma center, a stroke center, or cardiac intervention. Those are decisions you make based on your assessment. So here's what I want you to take away. Transport decisions aren't passive. They're not automatic. They are active clinical choices, and your patient's life may depend on how quickly and accurately you make them. Next, let's talk about where we take our patients, because the closest hospital isn't always the right hospital. As an AMT, it's your responsibility to think beyond distance. You have to consider destination capability. Can that facility provide the care your patient actually needs? If the answer is no, even if it's close, you may need to go farther. Now, of course, time matters, but so does getting the patient to definitive care. That's especially true in time-sensitive emergencies like stroke, STEMI, major trauma. In these cases, choosing the right specialty center, even if it's a little farther, can literally save a life. Let's look at some of those specialty centers. These are the kinds of facilities we need to keep on our mental map during every shift. First, trauma centers. These should be your go-to for patients with multi-system trauma, penetrating injuries, high-speed mechanisms, falls from significant height, or anything else that makes you say, this is bad. They're equipped to handle rapid surgical intervention, imaging, and critical care, and that's what these patients need. Next, let's talk about burn centers. If your patient has partial or full thickness burns over a significant surface area, especially involving the face, hands, feet, or airway, a regular ER may not have the tools to manage it. Burn centers offer fluid resuscitation, airway support, and long-term wound care that general hospitals can't provide. Now let's consider stroke centers. If you even suspect a stroke and the patient is within the treatment window, don't waste time. Take them to a stroke-ready facility. They need CT imaging, neurologic evaluation, and possibly clot-busting drugs or surgical intervention. That doesn't happen everywhere. Let's move on to cardiac centers. STEMI patients, those with classic chest pain and EKG changes, need rapid access to cardiac catheterization. That's not something a small rural hospital can always offer. And finally, we have pediatric and OB centers. For pregnant patients with complications or newborns in distress, you want to go where there's NICU support, OB emergency care, and pediatric trained teams. Don't assume every hospital is ready for a crashing newborn or a high-risk delivery. So what's the takeaway? You need to know your local system. Know which hospitals are trauma certified, stroke ready, PCI capable, burn equipped, and ready for OB or pediatric emergencies. And know how far they are from your usual response area. Because when seconds matter, you don't have time to figure it out on the fly. Remember, the best destination isn't always the closest one. It's the one that saves the patient's life. Let's move on to something that might seem basic but is often done wrong: positioning and packaging. How you position a patient during transport can affect more than just their comfort. It can impact their airway, their circulation, and their outcome. Let's start with positioning. There's no one-size-fits-all here. Your decisions need to match the patient's condition. So let's walk through the most common transport positions and when to use them. First up, supine. This is your standard position for trauma or shock patients. Why? Because it helps maximize cerebral and coronary perfusion. It allows blood to move more efficiently through the body when circulation is compromised. But if there's a specific reason not to use it, like a pregnancy or breathing issue, adjust accordingly. Next, left lateral recumbent. This one is key for third trimester pregnant patients. Why? Because when they lie flat, the uterus compresses the inferior vena cava, cutting off blood flow back to the heart. That leads to hypotension for the mother and the baby. Turning them to their left side helps relieve that pressure and restore perfusion. Every AEMT should know this and use it. Now let's talk about semi-Fowler's or Fowler's position. This is for patients with respiratory distress, trouble breathing, COPD, CHF, or asthma. Raising the head and chest makes it easier for the diaphragm to move and improves lung expansion. Just remember, don't use this if the patient is hypotensive or has a spinal injury that hasn't been cleared. Then there's the recovery position. Use this for unconscious patients who are breathing and have an intact airway. It helps keep the tongue from blocking the airway, and it allows fluids like vomit or blood to drain from the mouth, reducing the risk of aspiration. It's a simple move that can make a huge difference. Now, let's shift gears to packaging. Packaging means getting the patient secured and ready for transport safely and efficiently. That includes securing the patient to a stretcher or backboard, applying all safety straps, padding is needed, and protecting any injuries with splints or stabilization. Whether it's a fractured femur or a spinal precaution, your job is to prevent further harm during movement. So what's the big picture here? Positioning protects physiology. Packaging protects the patient. Together, they set the stage for a safer, smoother, and more effective transport. Don't treat it as an afterthought, because these decisions have consequences. Now, let's talk about interventions. Specifically, what do you do before transport, and what can wait until during transport? Because not everything needs to happen on scene. And in some cases, staying too long can actually harm your patient. As an AMT, you have to prioritize. You're constantly weighing two things. Will this intervention improve the patient's condition before we arrive? Is it necessary for safe transport? If the answer to either of those questions is yes, you handle it before you roll. If not, you move and do it en route. Let's break that down. Here are examples of interventions that often need to be done before transport. Airway management, because if they can't breathe, they can't survive the ride. Hemorrhage control. Bleeding has to be stopped quickly, especially if it's arterial or from a junctional area. Cervical spine stabilization. Especially in trauma patients, you've got to immobilize before movement. Basic oxygen administration. If the patient is hypoxic, don't wait. These are time-sensitive, life-saving actions. You don't delay them. Now, here are some things that can often be done during transport, if the situation allows. Secondary assessments, vital signs trending, medication administration, detailed history gathering, and rechecking interventions. These are still important, but they don't always need to delay the decision to go, especially not if the patient is unstable. Let's emphasize that again. Scene time should always be minimized for unstable patients. If someone is showing signs of shock, stroke, cardiac compromise, or altered mental status, you go. You do what you must to stabilize life threats, and then you move. Everything else comes second. Here's the mindset I want you to adopt. Fix what's fatal, package fast, and roll. The rest can ride with you. The best providers don't try to do everything on scene. They do what matters most, and they know when it's time to drive. Now it is time to transport. Transport is not a break. It's not a time to sit back and wait for the hospital to take over. As an AEMT, transport is still your responsibility, and that means constant reevaluation. Too often, providers think the hard part is over once the patient is in the ambulance. But here's the truth. Transport is not a passive process, it's active patient care. What happens in the back of the truck matters just as much as what happened on scene. So what are your priorities during transport? Let's start with the basics. First, vital signs. These aren't once and done. You're expected to trend them. For unstable patients, reassess vitals every 5 minutes. For stable patients, every 15 minutes is usually appropriate. Changes in blood pressure, pulse, respiratory rate, or mental status might be the first sign that something's getting worse or that your intervention is working. Second, ABCs. Always go back to airway, breathing, circulation. Did the airway stay open? Is breathing improving or deteriorating? Has circulation stabilized or is shock developing? Your initial treatment isn't a one-time fix. It needs constant evaluation. Third, adjustments and documentation. If the patient's status changes, you need to reassess your treatment plan, modify interventions if needed, and most importantly, document everything. What changed? What did you do about it? How did the patient respond? The documentation isn't just for legal protection. It tells the receiving team what's happened between point A and point B. This is how professionals operate. Driving the ambulance doesn't make you a passenger. You're still the clinician. Stay engaged, stay alert, and keep thinking like a provider all the way to the ER doors. No one is saying this is easy. Even well-trained providers can make critical mistakes when it comes to transport. Sometimes it's judgment, sometimes it's hesitation, and sometimes it's just not paying close enough attention. Let's go over the most common pitfalls AEMTs make and how to avoid them. Pitfall 1, failing to recognize signs of instability. This is probably the most dangerous mistake you can make. You see a patient who looks okay, but they're not. They're compensating. They're holding on for now. But underneath the surface, they're getting worse. Here's what you need to watch for. Tachycardia with normal blood pressure, that might be early shock. Mild confusion or disorientation, that could be a red flag. Increased work of breathing, especially with accessory muscle use or a silent chest, that's respiratory fatigue setting in. If you miss these signs, you may delay transport and your patient could crash. So remember this rule of thumb. If you're in doubt, treat the patient as unstable and go. You can always reassess in the truck. You can't undo a delay in care. Pitfall 2, misjudging the level of destination care needed. Not all hospitals are created equal, and choosing the wrong one can cost your patient precious time. Let's look at some examples. A burn patient with full thickness burns covering more than 10% of the body, they need a burn center, not the local ER. A stroke patient within the treatment window. They should go to a stroke-capable facility with rapid CT access and neurology support. A multi-system trauma patient, they belong at a level 1 or 2 trauma center if it's within an acceptable transport time. You need to know your regional protocols and what each hospital can and cannot do. And if you're not sure, err on the side of specialized care. It's better to over-triage than under-triage. Pitfall 3, improper patient positioning, post-injury or resuscitation. Positioning is more than comfort. It affects airway, circulation, and outcome. Let's look at a few common mistakes. First, laying a third trimester pregnant patient flat on her back. That can cause supine hypotensive syndrome by compressing the vena cava. Second, transporting a vomiting or seizing patient flat without airway support. That sets them up for aspiration. And third, not elevating the head of a head-injured patient when not contraindicated. That can increase intracranial pressure. Remember this. Positioning needs to support oxygenation, perfusion, and protection based on what the body is doing, not what's convenient. Pitfall 4, not considering airway protection during prolonged or altered LOC transport. If the patient has a decreased level of consciousness, the airway is at risk, period. You can't assume it will stay open. And during long transports, this becomes even more important. Here's what you need to be doing. First, reposition the patient as needed. Recovery position works if they're breathing on their own. Next, use basic adjuncts like OPAs or NPAs. Then, suction when necessary, secretions, vomit, blood. It all needs to be cleared. And most importantly, be ready to insert an advanced supraglottic airway. As an AEMT, devices like the King Airway, iGel, Combitube, and LMA are part of your scope of practice. If the airway is unprotected and you're trained, you need to act. Remember, don't assume the patient will make it to the hospital the way they left the scene. Protect the airway. Reassess constantly and stay ready.